You might know someone with high blood pressure. Maybe it's even a concern for you personally. But what if I told you that hypertension, often called the silent killer, affects almost half of American adults?
Yeah, it's a huge number.
And for those over 60, it's a staggering 74%.
Hmm.
Today, we're taking a deep dive into the complex world of antihypertensive agents, the drugs that help manage this incredibly widespread condition.
Right.
We've gone through some really comprehensive source material, everything from the latest clinical practice guidelines to detailed pharmacology texts. And our mission here is to unpack everything mentioned within this material.
All of it.
We want you to walk away from this deep dive feeling like an elite professional in this field, really understanding not just what these drugs do, but deeply grasping how and why they work and, what it all means for effectively managing this critical health issue.
What's truly remarkable, I think, is that despite how common it is, really understanding hypertension and its treatment, well, it means connecting a lot of dots. We're talking about everything from the body's intricate built-in control systems to the specific molecular actions of the various medications.
Yeah.
We'll explore it all step by step so you can really see the whole picture.
Okay, so let's unpack this first piece, hypertension. What exactly is it and why is it, such a major concern?
Right. Well, the official definition, based on those 2017 ACCHE guidelines, is pretty clear. Blood pressure at or above 130 over 90 millimeters of mercury.
130 and 90. Got it. And it's incredibly common, right?
Oh, absolutely. It's the most common cardiovascular disease out there, and actually the #1 reason people end up going to the doctor's office.
Wow. And the numbers you mentioned earlier, that NECS data.
Yeah, 2017 to 2018, it's 45% of American adults.
Almost half.
Almost half.
Yeah.
And then for adults 60 plus, it jumps to 74%. It's huge.
So the core problem then is this sustained high pressure damaging thing.
Exactly. It relentlessly damages blood vessels, particularly in vital organs like your kidneys, your heart, and your brain.
And that damage leads to?
Well, it significantly increases the risk of really serious life-altering conditions. Things like renal failure, coronary artery disease, heart failure, stroke, and even dementia.
The stakes are incredibly high then.
Extremely high. I mean, consider this. Over half of all deaths from coronary heart disease and stroke occur in people who actually have hypertension.
That's sobering.
It is. And a key insight here, I think, is that despite having effective medications, drugs that are proven to lower blood pressure, prevent that damage, and really reduce illness and death, unfortunately, only about half of Americans with hypertension actually have it under adequate control.
Only half. With effective treatments available.
Only half. Which, raises a really crucial question.
Right.
Why is achieving control so challenging? And what does it really take to tackle this widespread public health issue?
Okay, so if control is tough, let's back up to diagnosis first. How do we actually diagnose it? And what about individual risks?
Well, the diagnosis itself, it isn't usually based on symptoms.
Because there often aren't any, right? The silent killer thing.
Exactly. Not until it's very severe, often. So it relies on repeated, consistent measurements of elevated blood pressure. These are then categorized into stages, low, normal, elevated, stage 1, stage 2.
And what about that white coat hypertension? Is that a real thing?
Oh, definitely. Someone's pressure is high in the doctor's office, but normal otherwise.
Yeah.
That's precisely why confirming the diagnosis, often with home monitoring or even ambulatory monitoring where a device tracks you for 24 hours, is really the best approach.
Makes sense. Get a picture outside the clinic.
Right. And it's also vital to understand that there's a direct link between how high your blood pressure is and your risk of organ damage, kidney, heart, brain.
So even slightly elevated matters.
Absolutely.
Yeah.
Even what's called mild hypertension, say 130 over 80, significantly increases your long-term risk. The fact is, your risk of cardiovascular disease actually doubles with every 20 over 10 millimeter of mercury increase, starting from a baseline as low as 115 over 75.
Doubles. Wow. And what about just the top number being high, isolated systolic?
That's a common misconception, that it's somehow benign. It's absolutely not. It carries significant risk. The risks and the need to treat, they just go up proportionately with how high the pressure gets.
Okay. And besides the numbers themselves, what other risk factors are we looking at?
There are quite a few. Age is a big one. Race plays a role. African Americans, for example, face a greater risk. Gender, too. Premenopausal women generally have a lower risk than men.
Okay.
Then you've got smoking, and that includes secondhand smoke. Diabetes is a major factor. Metabolic syndrome, which usually involves obesity, unhealthy cholesterol levels, that sort of thing. Physical inactivity, any existing organ damage that's detected early on, And, of course, a family history of cardiovascular disease. All these pile on.
Okay, that's a lot to consider. Let's try and make this more concrete. You mentioned a patient case study in the source material.
Yes, a good example.
Right.
A 35-year-old man. His blood pressure is measured at 140/90.
Okay, so stage 1. Wait, 420/90 is stage 2 by the 1380 cutoff, right?
Correct. Stage 2 hypertension by the 2017 guidelines. He's generally healthy otherwise, but leads a sedentary lifestyle, drinks several cocktails daily, doesn't smoke though.
And his family history.
That's where it gets concerning. Strong family history of hypertension, and his father died of a heart attack at just 55.
Very young. Okay, what else?
On examination, he's moderately obese. His blood tests show high total cholesterol, low HDL, the good cholesterol, and his fasting glucose is 105 milli-GDL.
Which puts him in that pre-diabetes range.
Exactly. Chest x-ray's normal, but his ECG, the electrocardiogram, it shows left ventricular hypertrophy.
LVH. So his heart muscle is already thickening.
Correct. Already showing signs of strain from the high pressure. This patient's case, it's a really powerful real-world example. We'll keep coming back to him as we go, seeing how, someone aiming for that elite professional understanding would approach his treatment with all this knowledge.
Great. Okay, let's pivot now to the why. What actually causes hypertension?
Yeah, it's interesting. A specific single cause, we only find that in about 10 to 15% of patients.
Only 10-15%. So most cases.
Most cases, 85 to 90% we call essential or primary hypertension, meaning there's no single identifiable cause we can point to.
And the other 10-15%?
That's secondary hypertension. There's a specific cause. And finding these is really important because some of them are potentially curable, sometimes with surgery.
Like what kind of causes?
Things like a narrowed renal artery constriction, a congenital issue called coarctation of the aorta, certain tumors like pheochromocytoma, or hormonal issues like Cushing disease or primary aldosteronism.
Okay. But for essential hypertension, the vast majority, it's more complex.
Much more complex, usually multifactorial. It's a mix of interacting factors. Genetics definitely play a role. Heritability is estimated around 30%, usually involving multiple genes, not just one.
Polygenic.
Exactly. Then there's psychological stress. Environmental factors, especially diet, too much salt, maybe not enough potassium or calcium, regular alcohol consumption, and obesity is a big one.
That dietary link seems strong. I read something about low sodium populations.
Yes. That's a fascinating observation of the source material. In populations with consistently low daily sodium intake, blood pressure doesn't tend to increase with aging nearly as much as it does elsewhere. Really underscores that environmental dietary component.
Right. So while the exact cause is often murky for essential hypertension,
the body's normal blood pressure regulation mechanisms, those are incredibly well understood. And that understanding, that's precisely where our medications come into play. It's the foundation for how we treat it.
Okay, so how does the body normally regulate it?
Well, you can think of it with a simple hydraulic equation. Arterial blood pressure equals cardiac output times peripheral vascular resistance.
Okay, so how much blood the heart pumps out times how much resistance it meets in the vessels.
Exactly. And the body is constantly fine-tuning this pressure, making moment-to-moment adjustments in both cardiac output and that peripheral resistance. It does this mainly at 4 primary sites, sort of like control centers.
4 sites, what are they?
First, the arterioles, small arteries acting like resistance valves. Second, the postcapillary venules, small veins that hold blood, acting as capacitance vessels. Third, the heart itself, the pump. And fourth, the kidney, which is crucial for regulating the overall fluid volume in your bloodstream.
Arterioles, venules, heart, kidney. Got it.
And these sites don't work in isolation. They're constantly coordinated by rapid nerve reflexes, your baroflexes, and by hormones, especially the renin-angiotensin aldosterone system, or RAAS.
Okay, nerves and hormones coordinating those 4 sites.
Plus, there are local substances released right from the blood vessel lining itself. Things like endothelin-1, which constricts vessels, and nitric oxide, which dilates them. They add another layer of control over resistance.
So in hypertension, are these systems broken?
Not exactly broken, but it's like their set point for what's considered normal blood pressure has been dialed up higher. The mechanisms are still working, just maintaining that higher pressure.
Okay. So the goal of the drugs is to...
Exactly. All effective antihypertensive drugs work by intelligently interfering with one or more of these normal physiological control systems, those 4 sites and their regulators, to bring that set point back down towards normal.
Let's dive deeper into those control mechanisms then. You mentioned the baroflex and the kidney as critical players. Let's start with the baroflex.
Right, the postural baroflex.
Right.
This is your body's super fast, moment-to-moment adjustment system. Think about standing up quickly. You usually don't get dizzy or faint, right?
Okay.
That's this reflex at work. You have special sensors, mainly in your carotid arteries in your neck, called baroreceptors. They sense the stretch of the vessel walls, which reflects your blood pressure.
Okay, stretch sensors.
When they're stretched by normal pressure, they send signals that inhibit your central sympathetic nervous system, basically telling your body to ease off the accelerator a bit.
Okay.
But if there's a drop in stretch, say blood pools in your legs when you stand up, the baroreceptor activity lessens. This disinhibits the sympathetic outflow. It releases the brakes.
So more sympathetic activity.
A rapid surge, yes. This surge then acts through nerve endings to constrict your arterioles, boosting peripheral resistance. It also increases your heart's pumping action and constricts your veins, the capacitance vessels, pushing more blood back to the heart.
All to bring the pressure back up quickly.
Instantly. It's designed to restore normal blood pressure very fast. And this same powerful reflex kicks in if your blood pressure drops, for other reasons too, like if you take a drug that strongly dilates blood vessels, or if you lose fluid volume.
Okay, that's the rapid short-term fix. What about the kidney's role? You said that's more long-term.
Absolutely. The renal response to decreased blood pressure is central for long-term control, mainly through regulating your blood volume.
How does it do that?
When your kidneys sense a drop in the pressure of blood flowing through them, reduced renal perfusion pressure, they respond in a couple of ways. They redistribute blood flow internally, and crucially, they increase the reabsorption of salt and water back into your bloodstream.
Holding on to salt and water to boost volume.
Exactly. And here's where it gets really critical for our drug targets. That decrease in pressure in the kidney's small arterioles, along with stimulation from sympathetic nerves acting on specific beta-adrenoceptors, triggers the kidney to produce a key hormone called renin.
Renin, that kicks off the RAS system you mentioned.
Precisely. Renin acts on a protein circulating in your blood called angiotensinogen, chopping off a piece to create angiotensin thirst, which is inactive.
Okay.
Then, primarily by an enzyme called angiotensin-converting enzyme, or ACE, found mostly in the lining of blood vessels, angiotensin R gets converted into the very powerful angiotensin thirst.
Angiotensin II, what does that do?
Two main things relevant here. First, it's a potent vasoconstrictor. It narrows blood vessels directly, increasing resistance. Second, it stimulates your adrenal glands, which sit on top of your kidneys, to produce another hormone called aldosterone.
Aldosterone, we mentioned that with diuretics.
All right, aldosterone then tells your kidneys to reabsorb even more sodium, and water follows the sodium. This further increases your intravascular blood volume. So angiotensin II hits blood pressure from two angles, constricting vessels and increasing volume via aldosterone.
A powerful 1-2 punch for raising blood pressure.
Definitely. And we should briefly mention vasopressin too. That's a hormone released from the brain, also called antidiuretic hormone, which helps maintain blood pressure, mainly by telling the kidneys just to reabsorb more water.
Okay, so we have these intricate systems, baroreflexes, kidneys, RAAS, constantly working to regulate pressure.
Correct.
So now, here's where it gets really interesting for our deep dive. How do our medications actually intervene in these specific systems?
This is the core of antihypertensive pharmacology. The fundamental principle, as we said, is that all these agents work at one or more of those four anatomic control sites, arterioles, venules, heart, kidney, essentially, by messing with these normal regulatory mechanisms we just described.
Okay, and the source material groups them into categories based on how they interfere.
Exactly. Broadly, there are four main categories based on their primary target or mechanism. First, you have diuretics. They lower blood pressure, mainly by helping your body deplete sodium stores and reduce overall blood volume.
Get rid of salt and water.
Basically, yes.
Yeah.
Second, you have agents that block the production or action of renin or angiotensin. These work on that RAAS pathway we just detailed, primarily reducing peripheral vascular resistance and potentially blood volume too.
Targeting the RAAS system.
Correct. Third, there are direct vasodilators. These drugs work directly on the smooth muscle in blood vessel walls, relaxing them, widening resistance vessels, and some also increase capacitance in veins.
Relaxing the pipes directly.
You got it. And fourth, we have sympathoplegic agents. These lower blood pressure by reducing the activity of the sympathetic nervous system. This leads to reduced peripheral vascular resistance, inhibited cardiac function, and increased pooling of blood in the veins.
Okay. Diuretics, RAAS blockers, direct vasodilators, and sympathoplegics. Four big groups. The fact that they work differently, that's key for combining them, right?
Absolutely key. It directly addresses that question that often comes up. Why do so many patients need more than one drug? This leads us straight into the concepts of polypharmacy, using multiple drugs and resistant hypertension.
Resistant hypertension, that's when even multiple drugs aren't enough.
Essentially, yes. Many patients need 2 or more drugs working through different mechanisms. And for a significant chunk, maybe up to 40%, even 2 agents might not get them to their goal blood pressure. That's when we start talking about resistant hypertension.
Why is that? Why doesn't one drug always work?
There are 2 main reasons for needing multiple drugs. The first goes back to those compensatory mechanisms we talked about with the Baraflex. The body is incredibly good at trying to maintain its set point, even if it's too high.
So the body fights back against the drug?
In a way, yes. If you give, say, a direct vasodilator, it lowers resistance. But your body might reflexively speed up the heart rate and start retaining salt and water to try and compensate, push the pressure back up. That's a biological tug of war.
Oh.
So by combining drugs, maybe a vasodilator plus a beta blocker to block the heart rate increase, and a diuretic to prevent the fluid retention, you effectively counteract these compensatory responses. Each drug helps the others work better, making the whole system more sensitive to their combined effects.
Blocking the body's counter moves? Makes sense. What's the second reason?
The second reason is that some drugs, while maybe only having a modest effect on blood pressure when used alone, offer absolutely crucial long-term benefits beyond just lowering the number.
Like protecting organs.
Exactly. Think about ACE inhibitors. On their own, they might only lower blood pressure by, say, less than 10 points. But they provide vital long-term protection for the kidneys, especially in patients with diabetes, and improve outcomes significantly in heart failure.
So you need them for those benefits, even if they don't lower the pressure enough on their own.
Precisely. For someone with more severe hypertension, that modest BP lowering isn't enough to reach the target. So you combine it with other drugs to get the necessary blood pressure reduction while still getting those critical long-term protective effects. And sometimes, side effects limit how high you can push the dose of one drug, making combinations necessary to get adequate control without causing too much toxicity.
Okay, that explains the why behind combinations. So how do doctors typically approach starting and combining these? Is there a standard playbook?
Well, there's a traditional approach, and maybe a more modern, increasingly common one. Traditionally, a clinician might start with one drug monotherapy. If that wasn't enough after a trial period, they'd add a second drug from a different class, one with a different mechanism, and ideally different side effects.
That wise addition.
Right. And if 2 weren't enough, assuming the patient is actually taking the meds, a third drug would be added.
Okay. And the newer approach?
It's becoming much more common now, based on trial evidence, to actually start with small doses of 2 or sometimes even 3 drugs right from the beginning.
Starting with a combo. Why?
The idea is you can often get to the target blood pressure faster this way. And using lower doses of multiple drugs might actually lead to fewer overall side effects compared to pushing one single drug to its maximum dose. For instance, starting with a low-dose diuretic, an ACE inhibitor or an ARB, and maybe a calcium channel blocker.
Interesting. Faster control, potentially fewer side effects. What if even 3 drugs aren't cutting it?
Right. If a patient is on 3 drugs, usually including a diuretic, and their blood pressure is still stubbornly high, that's when clinicians really start digging for causes of resistant hypertension.
Looking beyond just needing more meds.
Exactly. Could it be something simple like the patient eating way too much salt? Are they taking other medications that raise blood pressure, like NSAIDs for pain or certain decongestants or stimulants? Or, importantly, could there be an underlying secondary cause of hypertension that was initially missed?
Going back to check for things like kidney artery stenosis or hormonal issues?
Precisely. In some resistant cases, even if no specific secondary cause is found, adding a 4th drug might be necessary. And a class called mineralocorticoid antagonists, like spironolactone, has proven quite useful here.
Spironolactone again.
Yes, and for those really rare, truly resistant patients, you reevaluate everything, maybe even consider investigational treatments like renal denervation, especially if they have advanced kidney disease.
Okay, that gives us a good framework for the overall strategy. Now, let's really get into the specifics of these drug classes, aiming for that deep, professional-level understanding. Let's start with diuretics. You said they're fundamental. How do they work exactly?
Right, diuretics. First, it's always worth remembering that simple dietary sodium restriction has been known for ages to lower blood pressure. It's safe and can even help prevent hypertension in the first place. Even modest salt reduction helps many people.
Good reminder. So the drugs themselves.
Their main action is depleting the body's sodium stores. Initially, when you start them, they reduce blood volume and cardiac output, which lowers pressure. Interestingly, peripheral vascular resistance might even increase slightly at first due to reflex mechanisms.
Okay, initially lower volume and output.
But then, after about 6 to 8 weeks, something interesting happens. Cardiac output usually returns to normal, or close to normal, but the peripheral vascular resistance declines.
So the long-term effect is lower resistance. Why?
It seems sodium itself plays a role in vascular stiffness and reactivity, maybe by affecting how calcium moves within the smooth muscle cells of the vessel walls. By reducing body sodium, diuretics or dietary salt restriction seem to reverse these effects, leading to less vascular resistance over time.
Fascinating. So they lower pressure initially by volume, but long-term more by resistance.
That appears to be the main mechanism, yes. And in terms of effectiveness, they're quite good. They can lower blood pressure by 10-15 millimeters of mercury in most patients, which is often enough for mild or moderate essential hypertension on its own.
And for severe cases.
They become absolutely crucial, almost always used in combination with other powerful drugs, like sympathoplegics or vasodilators. Why? Because those other drugs often cause the body to retain sodium, making blood pressure incredibly sensitive to even small changes in blood volume.
So the diuretic prevents that sodium retention caused by the other drugs?
Exactly. It controls the volume expansion, allowing the other drugs to work properly. In severe hypertension managed with these combos, blood pressure might be perfectly controlled if blood volume is, say, 95% of normal, but shoot right back up if it creeps up to 105%. Diuretics are essential to keep that volume in check.
Okay, absolutely critical in combinations then. Now, you mentioned different types of diuretics. How do clinicians choose?
Yes, the choice is nuanced, and this is key for understanding their use. For most patients with mild or moderate hypertension who have normal kidney and heart function, the thiazide diuretics are usually the go-to first choice.
Like hydrochlorothiazide or chlorthalidone.
Exactly. Hydrochlorothiazide, HCTZ, and chlorthalidone are the main ones. Chlorthalidone might last a bit longer, but a very large recent study actually showed HCTZ was just as effective for preventing major cardiovascular outcomes in older adults. A key point for thiazides is that for blood pressure lowering, lower doses, typically 25 to 50 milligrams, are generally just as effective as higher doses, even though higher doses cause more urination.
So no need for high doses for the BP effect. When would you need something stronger?
That's where loop diuretics come in. Drugs like furosemide, bumetanide, torsemide, these are much more potent diuretics.
When are they necessary?
They become necessary in several situations. Severe hypertension, especially when the patient is already on multiple other drugs that tend to cause sodium retention. If the patient has significant kidney insufficiency, say a GFR below 30 or 40 millilinen, or in conditions like heart failure or cirrhosis where there's already significant sodium retention happening.
So stronger diuretic action needed for those situations.
Right. Although, interestingly, some newer research suggests that even chlorthalidone might be effective for lowering blood pressure in patients with advanced chronic kidney disease, which wasn't previously thought. An important difference from thiazides is that the blood pressure response to loop diuretics continues to increase even at very high doses.
Okay. And the third type, potassium sparing.
Yes, potassium-sparing diuretics. These include drugs like spironolactone, eplerenone, amiloride, and triamterene. They're valuable for two main reasons. First, they help prevent the body from losing too much potassium, which is a common side effect of thiazide and loop diuretics.
Counteracting the potassium loss.
Exactly. And second, they can enhance the overall sodium excretion, the natriuretic effect, when used with other diuretics. Spironolactone and eplerenone are also known as aldosterone receptor antagonists. They have particularly favorable effects on heart function in people with heart failure, and they're also very useful as add-on therapy in resistant hypertension.
So they have unique benefits beyond just sparing potassium.
Definitely. And while we won't dive into every pharmacokinetic detail, tables in the source material provide specifics on half-lives, bioavailability, and how to adjust doses, especially for kidney issues, which is crucial for safe use.
Okay, that clarifies the different types and their uses, but what about the downsides? Toxicities, you mentioned potassium.
Absolutely. For thiazides and loop diuretics, the most common adverse effect is potassium depletion hypokalemia. While mild hypokalemia might be tolerated, it can be quite dangerous for certain patients.
Who's particularly at risk?
Patients taking digitalis for heart conditions, those with chronic heart rhythm problems, or individuals who've had a recent heart attack or have significant left ventricular dysfunction. Interestingly, potassium loss is linked to how much sodium the kidney tries to reabsorb, so sticking to that dietary sodium restriction can actually help minimize potassium loss.
Good tip. What other metabolic effects can happen?
Diuretics can also lead to magnesium depletion. They might slightly impair glucose tolerance, potentially unmasking diabetes. They can increase serum lipid concentrations, cholesterol, and triglycerides. And they can raise uric acid levels, which could precipitate a gout attack in susceptible individuals.
Sounds like a lot.
It does. But the good news is that using the lowest effective dose of the diuretic helps minimize most of these metabolic side effects without sacrificing the blood pressure lowering benefit.
Low dose is key. What about the potassium-sparing ones? They don't cause low potassium, but...
Right, they carry the opposite risk, hyperkalemia or too much potassium in the blood. This is especially a concern in patients who already have kidney insufficiency or are also taking other drugs that can raise potassium, like ACE inhibitors or ARBs.
Gotta watch potassium levels closely with them.
Definitely. And one specific side effect for spironolactone, because it's structurally similar to steroid hormones, is that it can cause gynecomastia, which is breast tissue development in men. Eplerenone is much less likely to cause this.
Okay, clear on diuretics and their nuances. Let's move to that other major player you highlighted. Drugs targeting the renin-angiotensin system. You said these are crucial, even in people with low renin level.
Yes, that's an important point. Inhibiting this system is effective across a wide spectrum of hypertensive patients. And to really grasp how these drugs work, we need to revisit that RAS pathway we outlined.
Right. Renin release is triggered by low kidney pressure, sympathetic stimulation, or changes in sodium delivery.
Correct. Renin then acts on angiotensinogen to make angiotensin first. ACE converts angiotensin first to the active angiotensin second.
And angiotensin II constricts vessels and triggers aldosterone release for sodium retention.
Exactly. Angiotensin II can also be converted to angiotensin III, which also stimulates aldosterone. This whole system is critical in driving high vascular resistance in conditions like renal artery stenosis or malignant hypertension. But it also plays a definite role in many cases of essential hypertension, and certainly in the body's compensatory responses to other treatments like diuretics.
And you mentioned a local tissue system, too.
Yes, there's evidence for angiotensin generation right within tissues like the heart, blood vessels, and kidney. This local RAAS might contribute more to slow trophic changes, like the cardiac hypertrophy, the heart muscle thickening we saw in our case study patient. ACE inhibitors seem to block this tissue production, too.
So multiple levels of impact for this system and the drugs targeting it.
There are three main classes acting directly on the pathway. First, the ACE inhibitors, which block that key conversion step. Second, the angiotensin receptor blockers, ARBs, which prevent angiotensin II from binding to its main receptor. And third, aliskiren, which is an orally active drug that directly inhibits renin itself, right at the start of the cascade.
ACE inhibitors, ARBs, and a direct renin inhibitor.
Right. And don't forget, we already discussed the aldosterone receptor inhibitors, spironolactone and eplerenone, which block the end product's effect. And beta blockers also reduce renin secretion, so they indirectly affect this system too.
Okay, lots of ways to intervene. Let's dissect the ACE inhibitors first. What makes them so unique and widely used? Captopril, enalapril, lisinopril.
Right. These drugs inhibit angiotensin-converting enzyme. And the key insight here is that ACE does two things. It converts inactive angiotensin to BECOM to the powerful vasoconstrictor, angiotensin II. But it also breaks down bradykinin.
Bradykinin, you said that's a vasodilator.
A potent vasodilator, yes. It works partly by stimulating the release of nitric oxide and prostacyclin. So ACE inhibitors have a dual action. They decrease the formation of the bad guy, angiotensin II, and they increase levels of the good guy, bradykinin, by preventing its breakdown.
Inhibiting vasoconstriction and promoting vasodilation.
Exactly. That dual mechanism is thought to contribute significantly to their effectiveness. We know the bradykinin part is important because if you give a drug that blocks bradykinin receptors, it partially blunts the effect of the ACE inhibitor.
Interesting. And many are pro-drugs.
Yes, many like enalapril are inactive prodrugs that need to be hydrolyzed, usually in the liver, to become the active form, enalapril. Lisinopril is an exception. It's active as is. And enalapril is also available for 5e use.
How do they affect hemodynamics, the actual blood flow and pressure?
They principally decrease peripheral vascular resistance, which lowers blood pressure. Importantly, cardiac output and heart rate are usually not significantly changed.
Unlike direct vasodilators, they don't cause that reflex tachycardia.
Generally, no. This makes them a safer choice for patients with ischemic heart disease. The reason might be that they help reset the sensitivity of the baroreceptors, or perhaps enhance parasympathetic activity.
And their clinical utility, where do they really shine?
They are particularly useful in patients with chronic kidney disease. They have a proven ability to diminish proteinuria, protein in the urine, and stabilize renal function, sometimes even independent of their blood pressure lowering effect. This is especially valuable in patients with diabetes.
Kidney protection is a major benefit.
Huge. They are now a cornerstone for diabetic nephropathy. They're also extremely useful in treating heart failure and are standard care after a myocardial infarction. There's even evidence they might reduce the incidence of new-onset diabetes in patients who are already at high cardiovascular risk.
Wow, broad range of benefits. How about pharmacokinetics, how the body handles them?
Most are eliminated primarily by the kidneys. This means the dose usually needs to be reduced in patients with renal insufficiency to prevent accumulation. There are a couple of exceptions, like fosinopril and mogapril, which have significant excretion through the liver as well. Details are in the tables in our source material.
Okay. Now, the crucial part, toxicity. What are the main side effects?
Severe hypotension, a big drop in blood pressure, can occur with the very first dose, especially in patients who are volume depleted, maybe from aggressive diuretic use.
Need to start low, especially in those patients.
Definitely. Acute renal failure is a serious, though uncommon risk, particularly in patients who have narrowing in the arteries supplying both kidneys, bilateral renal artery stenosis or stenosis in the artery, to a single functioning kidney.
Why is that?
Because in those situations, the kidney's blood flow becomes critically dependent on angiotensin II's constricting effect on the outgoing arteriole to maintain filtration pressure. Blocking angiotensin II can cause a precipitous drop in filtration.
Okay, a very specific contraindication. What else?
Hyperkalemia, too much potassium, is another risk, more likely in patients with renal insufficiency or diabetes, or those taking potassium supplements or potassium-sparing diuretics.
The interaction we mentioned earlier.
Right. And then there are the side effects linked to bradykinin. A persistent dry cough, sometimes with wheezing, affects a significant minority of patients. And angioedema, that swelling, usually of the lips, tongue, throat, is less common but potentially life-threatening.
Cough and angioedema due to bradykinin buildup.
Believed to be yes, possibly, along with substance P accumulation. Critically, ACE inhibitors are absolutely contraindicated in the second and third trimesters of pregnancy. They can cause fetal hypotension, kidney failure, malformations, even death. And recent evidence suggests potential risks even in the first trimester.
Must avoid in pregnancy. Any other notable side effects?
Captopril, especially at high doses or in renal failure, was associated with neutropenia and proteinuria, but less common with others. Minor effects across the class can include altered taste, skin rashes, and occasionally drug fever. And the important drug interactions, potassium supplement-sparing diuretics, hyperkalemia risk, and NSAIDs, which can blunt the hypotensive effect partly by blocking that bradykinin-mediated vasodilation.
Okay, a thorough overview of ACE inhibitors. So if that cough or angioedema is a problem, the alternative is?
The angiotensin receptor blocking agents, or ARBs, losartan, valsartan, telmisartan, many others.
How do they differ from ACE inhibitors?
Their mechanism is different. Instead of blocking the production of angiotensin II, they selectively block its action at its main receptor, the angiotensin II type 1 or AT1 receptor.
Blocking the receptor, not the enzyme.
Exactly. The key difference that stems from this is that ARBs have no effect on bradykinin metabolism.
So no bradykinin buildup.
Correct. This makes them more selective inhibitors of angiotensin's actions. And arguably, they might provide more complete inhibition of angiotensin effects compared to ACE inhibitors, because some angiotensin II can be generated by enzymes other than ACE, and ARBs would still block its action at the receptor.
Interesting. Do they offer similar benefits?
Yes, generally. They show similar benefits to ACE inhibitors in patients with heart failure and chronic kidney disease. Their overall adverse effect profile is also quite similar, including the absolute contraindication during pregnancy.
But the big advantages?
The big advantage is that the incidence of cough and angioedema is much, much lower, comparable to placebo. This is why many clinicians now prefer to start with an ARB, especially if there's concern about those specific side effects.
Makes clinical sense. You mentioned combining ACEIs and ARBs isn't recommended.
Correct. Or combining either with the direct renin inhibitor, eliscurin. While it seemed logical to try and achieve a dual blockade of the RAAS, large clinical trials unfortunately demonstrated increased toxicity, things like hyperkalemia and kidney problems, without providing significant additional clinical benefit. So combinations generally avoided now.
Good to know. You mentioned valsartan is used with sacubitril.
Yes, that's a specific combination product, Entresto, used very effectively for heart failure. Sacubitril inhibits an enzyme that breaks down natriuretic peptides, which are beneficial, so the combo targets two systems. And briefly, aliskiren, the direct renin inhibitor, it works, but its overall place isn't as established, and it shares similar toxicities like hyperkalemia and the pregnancy contraindication.
Okay, that covers the RAS inhibitors thoroughly. Let's move to the next major category. Direct vasodilators. Drugs that work right on the blood vessels.
Right. Their general mechanism is straightforward. They relax the smooth muscle of arterioles, the resistance vessels, which decreases systemic vascular resistance and lowers blood pressure. Some, like nitroprusside and nitrates, also relax veins, the capacitance vessels.
And we need to remember those compensatory responses again.
Absolutely. Because they directly lower pressure, they trigger those baroreceptor reflexes, sympathetic nervous system activation, and RAAS activation. This is why, as a rule, vasodilators work best when they're used in combination with other drugs that oppose these compensatory effects, like beta blockers and diuretics.
Makes sense. Do they cause orthostatic hypotension?
Generally not, because those sympathetic reflexes are still intact, unlike with some of the older nerve-blocking agents. Sexual dysfunction is also not typical.
Okay, let's look at some key oral vasodilators first. Hydralazine.
Hydralazine. It works by dilating arterioles, but importantly, not veins. It's been around a long time. Initially, its effectiveness was sometimes underestimated because tolerance, or tachyphylaxis, could develop quickly if used alone.
Because of those compensations kicking in.
Exactly. But once clinicians understood the benefits of combining it, especially with beta blockers and diuretics for severe hypertension, its value became clear.
Where is it particularly useful now?
The combination of hydralazine with nitrates has proven very effective in treating heart failure, particularly in African American patients, based on trial data. So it's a strong consideration for patients who have both hypertension and heart failure, especially if they can't tolerate ACE inhibitors or ARBs.
How does the body handle it? Bioavailability.
It's well absorbed, but has relatively low and variable bioavailability, maybe around 25% on average. This is due to extensive first-pass metabolism in the liver, partly by a process called acetylation. And people differ genetically in how fast they acetylate.
Rapid versus slow acetylators.
Right. Slow acetylators tend to have higher blood levels from the same dose. Its plasma half-life is short, maybe 1.5 to 3 hours, but its effects on blood vessels last much longer, possibly because it binds tightly to vascular tissue.
Okay. What about its side effects?
Common ones include headache, nausea, loss of appetite, palpitations, sweating, and flushing. Because it triggers reflex tachycardia and sympathetic stimulation, it can sometimes provoke angina or ischemic arrhythmias in patients who already have coronary artery disease.
Need caution in those patients. What about the lupus-like syndrome?
Yes, that's a significant one. At higher doses, say 400 milligrams per day or more, especially in slow acetylators, about 10–20% of patients can develop a syndrome resembling systemic lupus erythematosus. Symptoms include joint pain, muscle aches, skin rashes, and fever.
Is it dangerous?
Importantly, it's not associated with kidney damage, unlike true lupus, and it's completely reversible when the drug is stopped.
Yeah.
Less common side effects include peripheral neuropathy and drug fever.
Okay, that's hydralazine. What about minoxidil? You said it's very potent.
Very efficacious, yes. It's actually activated in the body to minoxidil sulfate. This active form works by opening potassium channels in smooth muscle cell membranes.
Opening potassium channels, how does that lower pressure?
Opening these channels hypopolarizes the cell membrane, makes it more stable at its resting potential, and therefore makes contraction less likely. It causes profound relaxation of arterial or smooth muscle. Like hydralazine, it dilates arterioles but not veins.
And when is it used?
Because it's so potent, it's generally reserved for severe, often drug-resistant hypertension. It often replaces hydralazine when maximal doses of that aren't effective, or it's used in patients with renal failure and severe hypertension who haven't responded well to other treatments.
Sounds like a powerful tool for tough cases. Does it also need combination therapy?
Absolutely essential, even more so than hydralazine. Minoxidil causes very strong reflex sympathetic stimulation, tachycardia, increased cardiac output, and significant sodium and fluid retention. So it must be used in combination with both a beta blocker and a loop diuretic, often at high doses, to counteract these effects.
Crucial combo. What are its main toxicities?
Tachycardia, palpitations, angina, and edema, swelling, can all occur if the co-administered beta blocker and diuretic doses aren't adequate. Headache and sweating are also common. And then there's hypertrichosis,
Hypertrichosis.
excessive hair growth. It occurs in a majority of patients after several weeks. It's particularly noticeable on the face, back, arms, and legs, and can be quite bothersome, especially for women.
Ah, and that's the connection to topical minoxidil for hair loss.
Exactly, Rogaine. It perfectly illustrates how a side effect of a systemic drug was turned into a targeted topical therapy.
Fascinating. Okay, those are the oral ones. Now, for the parenteral vasodilators used in emergencies, sodium nitroprusside first.
Right. Nitroprusside is a powerful vasodilator given intravenously, primarily for hypertensive emergencies and sometimes for severe heart failure to reduce workload on the heart.
How does it work differently?
A key difference is that it dilates both arterial and venous vessels. This reduces both peripheral vascular resistance, afterload, and venous return, preload. It works very rapidly by releasing nitric oxide or perhaps directly stimulating guanylyl cyclase in vascular smooth muscle. This increases intracellular cyclic GMP, which leads to relaxation.
Balanced arterial and venous dilation, how does that affect hemodynamics?
It consistently lowers blood pressure. Cardiac output might stay the same or slightly decrease in people without heart failure. However, in patients with heart failure and low cardiac output, nitroprusside often increases cardiac output because it significantly reduces the resistance the failing heart has to pump against.
So useful in heart failure emergencies too. How is it given?
It's metabolized extremely rapidly in red blood cells, releasing nitric oxide and cyanide. Its effects disappear within 1 to 10 minutes after stopping the infusion. This means it has to be given by continuous IV infusion, allowing for very precise minute-to-minute titration of the dose based on the blood pressure response. Requires close monitoring, often with an arterial line for continuous BP reading, and it's light-sensitive, so the solution needs to be fresh and covered.
Rapid on, rapid off. What about toxicity? You mentioned cyanide.
Yes. Besides the risk of lowering blood pressure too much or too fast, the most serious toxicity is the potential accumulation of cyanide, one of its breakdown products.
Cyanide poisoning.
It can happen, especially with high infusion rates, prolonged use, or in patients with kidney problems. It manifests as metabolic acidosis, arrhythmias, severe hypotension, and can be fatal. Prophylaxis or treatment involves giving agents like sodium thiosulfate, which helps the body detoxify cyanide, or hydroxycobalamin.
Requires extreme caution then. Any other issues?
Thiocyanate, another metabolite, can accumulate with prolonged administration, especially with kidney impairment. This can cause weakness, disorientation, psychosis, muscle spasms, and convulsions. It can also, rarely, cause delayed hypothyroidism. Methemoglobinemia has also been reported.
Okay. What about diazoxide? You said it's not really used for hypertension anymore.
Correct. The parenteral form for hypertensive emergencies is no longer available in the U.S. It's an effective, relatively long-acting drug that, like minoxidil, works by opening potassium channels, causing hyperpolarization in smooth muscle. It's primarily an arteriolar dilator.
So why isn't it used for BP now?
Historically, the initial recommendations involved a rapid IV bolus of a large dose, which sometimes led to excessive and unpredictable hypotension, potentially causing stroke or MI. The reflex sympathetic response could also provoke angina or heart failure.
So safety concerns with the old dosing. But it is still used for something.
Yes. Because it also opens potassium channels in the beta cells of the pancreas, it inhibits insulin release. So in the U.S., it's now primarily used orally to treat hypoglycemia, low blood sugar, caused by conditions where the body produces too much insulin, like an insulinoma.
Interesting switch in indication. It's chemically similar to thiazides?
Yes, structurally, but it has no diuretic activity. In fact, when used for hypertension, it caused renal salt and water retention, though this was less of an issue with short-term emergency use. It could also cause hyperglycemia.
Okay. Then there's phenaldopim?
Phenaldopim is another parenteral vasodilator used for hypertensive emergencies and sometimes postoperative hypertension. It works primarily as an agonist of dopamine D1 receptors.
Dopamine receptors. How does that lower blood pressure?
Activating D1 receptors causes dilation of peripheral arteries, including renal arteries, and also promotes sodium excretion by the kidneys, diuresis.
So vasodilation plus a diuretic effect.
Essentially, yes.
Yeah.
It's rapidly metabolized, has a short half-life of about 10 minutes, so it's given as a continuous 5E infusion.
Side effect.
Similar to other vasodilators. Reflex tachycardia, headache, flushing. An important caution is that it can increase intraocular pressure, so it should be avoided in patients with glaucoma.
Good to know. That covers the direct vasodilators. What about the calcium channel blockers, CCBs? We mentioned them as a first-line option.
Yes, a very important and widely used class. Verapamil, diltiazem, amlodipine, nifedipine, many others. Their main mechanism in hypertension is inhibiting the influx of calcium into arterial smooth muscle cells.
Less calcium entry means?
Less contraction, more relaxation of the smooth muscle. This leads to vasodilation, reduced peripheral vascular resistance, and lower blood pressure.
Are they all the same?
No, there are important differences, particularly between the non-dihydropyridines, verapamil and diltiazem, and the dihydropyridine family, amlodipine, nispetalpine, nicardipine, etc. Clofidipine is a newer IV dihydropyridine. While they're all generally effective at lowering BP, they have different effects on the heart. The dihydropyridines, like amlodipine or nifedipine, are generally more selective as vasodilators and have less direct depressant effect on the heart muscle itself. They might cause a slight reflex increase in heart rate, and cardiac output is usually maintained or slightly increased.
More vessel-focused? What about verapamil?
Verapamil has the most pronounced cardiac depressant effect. It can slow the heart rate and potentially decrease cardiac output. It's also used for certain arrhythmias.
And diltiazem?
Diltiazem is kind of intermediate between verapamil and the dihydropyridines in its cardiac effects.
Important differences for choosing the right one. Is there a warning about short-acting forms?
Yes, a critical one. Short-acting oral dihydropyridines, like immediate-release nifedipine, are generally not recommended for treating hypertension. Some studies link their use to an increased risk of myocardial infarction or mortality, possibly due to rapid swings in blood pressure and reflex sympathetic activation.
So sustained release or naturally long-acting CCBs are preferred?
Absolutely. For chronic hypertension management, sustained release formulations or drugs with inherently long half-lives like amlodipine are the standard of care. Parenteral CCBs, IV nicardipine, clofidipine, and also verapamil and diltiazem are available for situations where oral therapy isn't feasible or for managing acute hypertension, like during surgery.
Okay, that gives us a solid grasp on CCBs. Now let's tackle the last major category, drugs modulating the sympathetic nervous system. You said this is complex with different sites of action.
Very complex, yes. The underlying principle is that sympathetic neural activation can initiate or sustain high blood pressure in many patients. So drugs that interfere with this system can be very effective, often necessary for optimal control in moderate to severe hypertension.
And classifying them by site of action helps.
It does. It helps understand their specific effects and side effect profiles. Think back to that sympathetic reflex arc we discussed. Signals from the brain, down the nerves, releasing norepinephrine at the target organ. These drugs can act centrally in the brain within the nerves themselves or at the receptors on the target cells.
Different points of intervention. What about general toxicities?
Yeah. Drugs acting in the central nervous system often cause sedation or mental depression. The old ganglion blockers had intolerable side effects because they blocked everything. Drugs inhibiting norepinephrine release mimic surgical sympathectomy to some extent, and drugs blocking specific receptors have more targeted effects.
And you mentioned they almost always need a diuretic.
Crucial point. All sympathoplegics can trigger compensatory sodium retention and volume expansion by the kidneys, so their effectiveness is almost always enhanced, and sometimes only revealed when used in combination with a diuretic.
Got it. Let's start at the top then, in the brain, with centrally acting sympathoplegic drugs. You said these aren't used much anymore, except clonidine.
Right. They were once staples, but newer agents are generally preferred now. Their mechanism involves reducing sympathetic outflow from the vasomotor centers in the brainstem. But importantly, they seem to retain or even increase the sensitivity of these centers to baroflex input.
So they lower sympathetic drive, but preserve the reflex buffer.
To some extent, yes. This generally results in less postural hypotension compared to drugs acting peripherally. Let's look at methyldopa.
Still used in pregnancy, right?
Primarily, yes.
Yeah.
It's an analog of L-dopa and gets converted in the body to active metabolites, like alpha-methylnorepinephrine. This metabolite is thought to stimulate central alpha-adrenoceptors, probably alpha-2 receptors, which inhibits sympathetic outflow.
So it acts centrally and not peripherally.
Its antihypertensive action is primarily central, yes. Hemodynamically, it lowers BP chiefly by reducing peripheral vascular resistance, with variable effects on heart rate and cardiac output. Most cardiovascular reflexes remain intact. It doesn't usually cause marked postural hypotension, although it can occur. A potential advantage is that it tends to reduce renal vascular resistance.
How does the body handle it?
It enters the brain via an amino acid transporter. Its peak effect is about 4 trace hours after a dose, but the effect can last up to 24 hours, likely because the active metabolite accumulates and is stored in nerve endings.
What about its side effects? Sedation?
Sedation is common, especially initially. Long-term, patients might experience mental lassitude, impaired concentration. Less commonly, nightmares, depression, vertigo, even Parkinson-like extrapyramidal signs. Lactation can occur in both men and women due to effects on prolactin secretion.
And the Coombs test.
Yes, a positive Coombs test develops in 10–20% of patients on long-term therapy. Rarely, this is associated with hemolytic anemia. Hepatitis and drug fever can also occur, but are reversible upon stopping the drug. But its main use now, as you said, is for hypertension during pregnancy, due to its established safety record.
Okay. Now, clonidine. How does it work?
Clonidine is chemically different, an imidazoline derivative. Its main hypotensive effect is exerted at alpha-adrenal receptors, likely alpha-2, in the medulla of the brainstem. This reduces sympathetic tone and increases parasympathetic tone, leading to both BP lowering and bradycardia, slow heart rate. It also seems to make the vasomotor centers more sensitive to baroflex inhibition.
Yeah.
It might also bind to other non-adrenoceptor imidazoline receptors, which could contribute.
How does it affect hemodynamics compared to methyl-dopa?
It generally lowers heart rate and cardiac output more significantly than methyl-dopa. It effectively reduces BP even when lying down and rarely causes postural hypotension. Only massive overdoses tend to cause paradoxical pressor effects.
And pharmacokinetics.
It's lipid-soluble, enters the brain rapidly. It has a relatively short half-life, so oral dosing is usually twice daily for smooth control. Alternatively, a transdermal patch provides 7-day delivery, which often causes less sedation but can lead to skin reactions. The dose response is tricky. Increasing doses give more effect, but also significantly more toxicity.
Toxicity, dry mouth and sedation again.
Very common, yes. Central effects and dose-dependent. Should be avoided in patients prone to depression. Tricyclic antidepressants can block its effect, but the most critical toxicity is the withdrawal syndrome.
You emphasized this earlier. What happens?
If clonidine is stopped abruptly, especially from high doses, there can be a rapid rebound in sympathetic activity. Patients experience nervousness, tachycardia, severe headache, sweating, a hypertensive crisis. It can be life-threatening.
So patients must be warned.
Absolutely warned never to stop it suddenly. Discontinuation must be gradual while other agents are introduced. If a crisis occurs, treatment involves restarting clonidine or using alpha and beta blockers. Other similar drugs like guanabens and guanfacine exist but are rarely used now.
Okay, clear warning on clonidine withdrawal. What about those older drugs acting on nerve endings, the ganglion blockers?
Historically important as the first effective antihypertensives, but abandoned due to intolerable side effects. They blocked transmission in all autonomic ganglia, both sympathetic and parasympathetic.
So side effects were widespread.
Extremely. Sympathetic blockade caused severe orthostatic hypotension and sexual dysfunction. Parasympathetic blockade caused constipation, urinary retention, glaucoma worsening, blurred vision, dry mouth. Just too many problems for routine use.
Makes sense why they were dropped. Then the adrenergic neuron blockers, like guanethidine.
Also rarely used now due to significant toxicity, and guanethidine isn't available in the U.S. anymore. It worked by getting taken up into sympathetic nerve endings and replacing norepinephrine in the storage vesicles, leading to gradual depletion. It was too polar to enter the CNS.
What were its main problems?
At effective doses, it caused profound sympathoplegia marked postural hypotension with exercise. Diarrhea was common due to unopposed parasympathetic activity in the gut. Impaired ejaculation was also frequent. Many drug interactions, too.
Okay. And rezapine, another historical one.
Yes, from the Rauwolfia plant. Also rarely used now, not available in the U.S. It worked differently by irreversibly blocking the transporter, VAND, that loads amines like norepinephrine, dopamine, and serotonin into storage vesicles in both peripheral nerves and the brain.
So depletion of alkamines everywhere.
Yes. Peripheral depletion lowered BP. Central depletion caused the major side effects: sedation, lassitude, nightmares, and potentially severe mental depression, even at low doses. Parkinson-like extrapyramidal effects could also occur. It also increased gastric acid secretion, so avoided in ulcer patients. Again, the side effect profile limited its use.
Right, these older agents highlight the search for more targeted therapies, which brings us to the adrenoceptor antagonists. Beta blockers first.
Yes, a cornerstone group. Beta adrenoceptor blocking agents. Blockers. Very effective for mild to moderate hypertension, especially useful in severe hypertension to prevent that reflex tachycardia from direct vasodilators. And crucially, they reduce mortality after MI and in heart failure, giving them an advantage in patients with those conditions plus hypertension.
Let's start with propranolol, the original non-selective one.
Exactly, the prototype. It blocks both beta-1 and beta-2 receptors throughout the body. Its main mechanism for lowering BP is decreasing cardiac output. It also inhibits renin production by blocking beta-1 receptors in the kidney. It works regardless of the patient's baseline renin level, It might also reduce sympathetic nerve activity centrally or presynaptically.
Side effects are due to blocking both beta-1 and beta-2.
Primarily, yes. Beta-1 blockade in the heart can cause bradycardia or worsen conduction problems. Beta-2 blockade can cause problems in patients with asthma, bronchoconstriction, peripheral vascular disease, reduced blood flow, or diabetes, masking hypoglycemia symptoms, impairing glucose regulation.
And the withdrawal syndrome applies here too.
Yes, definitely. Abrupt discontinuation after prolonged use can lead to nervousness, tachycardia, worsening angina, increased BP, sometimes even MI. This is thought to involve upregulation or supersensitivity of beta receptors. So, again, never stop beta blockers abruptly. Taper them off.
Okay. What about the more common cardioselective ones?
Right.
Proprolol and atenolol.
Right, these are the most widely used. They preferentially block beta-1 receptors, mainly found in the heart, with much less effect on beta-2 receptors elsewhere.
What's the advantage of being beta-1 selective?
It's a significant advantage for patients who also have asthma, diabetes, or peripheral vascular disease, as these drugs are less likely to worsen those conditions. However, the selectivity is dose-dependent and not absolute, especially at higher doses.
How do metoprolol and atenolol differ?
Metoprolol is extensively metabolized by the liver via the CYP2D6 enzyme. Extended-release formulations allow once-daily dosing and are proven to reduce mortality and heart failure. Atenolol is not significantly metabolized and is excreted by the kidneys. While often dosed once daily, some data suggest it might be less effective than metoprolol in preventing complications, possibly because once-daily dosing doesn't provide consistent 24-hour coverage for everyone. Atenolol doses need to be reduced in kidney impairment.
Are there others?
Yes, quite a few. Nadolol and cardiolol are non-selective, renally excreted. Pitaxolol and bisoprolol are beta-1 selective with long half-lives. Pindolol, acebutolol, pibitolol have some intrinsic sympathomimetic activity, partial agonists, but are rarely used.
And then there are those with combined effects. Labetalol, carvedilol, nebivolol.
Right, these are interesting. They combine beta blockade with vasodilation through different mechanisms. Labetalol blocks both beta and alpha-1 receptors with about a 3.1 ratio of beta to alpha blockade orally. It lowers BP mainly by reducing systemic vascular resistance due to alpha blockade without significantly changing heart rate or cardiac output. Very useful in pheochromocytoma and IV for hypertensive emergencies.
Carvedilol, also alpha and beta.
Yes, it's a non-selective beta blocker with alpha-1 blocking activity. It's particularly noted for reducing mortality and heart failure, so it's a great choice for patients with both conditions.
And nebivolol, it's different.
Yes, it's beta-1 selective, but its vasodilation is not due to alpha blockade. It seems to work by increasing the release of nitric oxide from the vascular endothelium. So unlike older beta blockers, it acutely lowers peripheral vascular resistance.
Interesting mechanism. Lastly, for beta blockers, esmolol.
Esmolol is unique. It's beta-1 selective and is metabolized extremely rapidly by esterases in red blood cells. Its half-life is only about 9–10 minutes.
Super short-acting.
Incredibly short. It's given by continuous IV infusion and is used mainly for intraoperative or postoperative hypertension and sometimes in hypertensive emergencies, especially when you need very tight, rapidly adjustable control, perhaps due to concerns about underlying severe heart failure.
Okay, that covers the diverse world of beta blockers. Now for the alpha blockers.
Prazosin and the others.
Right, prazosin, terazosin, doxazosin. These selectively block alpha-1 receptors found on vascular smooth muscle in both arterioles and venules.
Alpha-1 selective. How does that compare to non-selective alpha blockers? A key advantage is they produce less reflex tachycardia when lowering blood pressure. This is because they don't block the presynaptic alpha-2 receptors, which normally act as a negative feedback brake on norepinephrine release from nerve endings. Non-selective blockers inhibit this brake.
So smoother BP lowering, how do they affect hemodynamics?
They reduce arterial pressure by dilating both resistance, arterioles, and capacitance, venules, vessels. Blood pressure is typically lowered more in the upright position than when lying down.
Do they need to be combined?
Yes, like other vasodilators, salt and water retention can occur with chronic use if used alone. So they are generally more effective when used with other agents, typically a beta blocker and/or diuretic.
What's their main clinical niche now?
Their primary use today is actually in men who have both hypertension and benign prostatic hyperplasia, BPH. This is because blocking alpha-1 receptors also relaxes the smooth muscle in the prostate and bladder neck, improving urinary symptoms.
Dual benefit for those patients. What about that first dose phenomenon?
Yes, that's important. Some patients can experience a precipitous drop in standing blood pressure shortly after taking the very first dose. It's more common in patients who are already salt or volume depleted.
How to manage it.
Advise patients to take the first dose as a small dose, right at bedtime. Subsequent doses are usually well tolerated. Other side effects are relatively infrequent and mild, maybe some dizziness, palpitations, headache, or lassitude. They might slightly improve lipid profiles, but no proven clinical outcome benefit from that.
And the non-selective alpha blockers, phentolamine, phenoxybenzamine.
Those are generally reserved for specific situations like managing the hypertension associated with pheochromocytoma, or sometimes for treating the hypertensive crisis from clonidine withdrawal, not for routine hypertension.
Okay, we have now gone through all the major drug classes in incredible detail. Diuretics, RAAS inhibitors, vasodilators, sympathoplegics, including beta and alpha blockers. That's a huge amount of pharmacology. Now let's put it all together. How do clinicians actually manage hypertension in practice, given it's often this lifelong asymptomatic condition?
Right, translating all this pharmacology into clinical action. The first step, absolutely crucial, is confirming persistent hypertension. That means reliable measurements, ideally multiple readings over several visits, or even better, home or ambulatory monitoring.
Get an accurate picture first.
Exactly. And remembering that isolated systolic hypertension and hypertension in the elderly definitely benefit from therapy too. The decision to start treatment considers the BP level, age, any existing organ damage, and overall cardiovascular risk factors.
Using those risk calculators and guidelines.
Precisely. Guidelines like treating O14E90 if 10-year risk is low, but O13E80 if 10-year risk is high. Checking kidney function and looking for proteinuria are also key inputs for deciding when and how to treat.
And patient education.
Absolutely essential. Patients need to understand the natural history of untreated hypertension, why treatment is vital even if they feel fine, the importance of adherence, and potential side effects to watch for. For essential hypertension, therapy is usually started gradually. Regular follow-ups, simplifying dosing schedules, and encouraging home BP monitoring all help improve compliance, which is paramount.
Before jumping to meds, though, what about those non-pharmacologic approaches? How much impact can they really have?
They can have a huge impact, and they are truly the foundation. Dietary sodium restriction, aiming for that 70-100 milliliter a day, mainly by avoiding processed foods, is highly effective.
Weight reduction.
Can normalize BP in a large percentage, maybe up to 75%, of overweight patients with mild-moderate hypertension. It's incredibly powerful.
Diet composition.
Diets like DHH rich in fruits, vegetables, low-fat dairy, significantly lower BP. Moderating alcohol intake is important. Using salt substitutes where potassium replaces sodium has shown benefits for BP and CV events. Regular exercise consistently helps.
And identifying things that raise BP.
Critical. Eliminating or minimizing drugs like sympathoplegic decongestants, NSAIDs, estrogen-containing contraceptives, stimulants, excessive caffeine, some herbal remedies that can make a big difference.
Okay, so lifestyle is foundational. But when medication is needed, how do we choose the right pharmacologic management approach for outpatients?
For mild hypertension, a single drug might do it. But as we discussed, low-dose combination therapy right from the start is increasingly common, potentially better effectiveness and fewer side effects. For moderate to severe hypertension, most patients will definitely need 2 or more medications.
Which drugs are considered first line now?
Based on large trials showing they reduce complications, the main first-line choices are thiazide diuretics, ACE inhibitors, angiotensin receptor blockers, ARBs, and calcium channel blockers, CCBs.
What about beta blockers? They used to be first line.
They are generally not recommended as first line for uncomplicated hypertension anymore. Large trials showed they were less effective than diuretics, ACE-ARBs, or CCBs in reducing overall cardiovascular events like stroke.
That's a significant shift. And that big trial comparing classes, ALLHAT.
Yes, the ALLHAT trial was very influential. It found that the thiazide diuretic chlorthalidone was basically as effective as the other agents, amlodipine, lisinopril, for the primary outcome of CHD death or non-fatal MI. It was actually superior to the CCB amlodipine in preventing heart failure and superior to the ACE inhibitor lisinopril in preventing stroke, really cemented the role of thiazides.
So those 4 classes are the main starting points. How do other health conditions influence the choice?
Hugely. We call this tailoring therapy based on compelling indications or concomitant diseases. For example, if a patient has diabetes or chronic kidney disease with protein in their urine, an ACE inhibitor or ARB is strongly preferred due to their kidney protective effect.
Makes sense. What about angina?
For angina, beta blockers or calcium channel blockers are good choices as they help with both conditions.
Heart failure.
Several options work well. Diuretics, ACIs, ARBs, beta blockers, specific ones like metoprolol succinate, carvedilol, bisoprolol, and the hydrolysine nitrate combination, or aldosterone antagonists.
And for men with BPH.
Alpha-1 blockers are often chosen because they treat both the hypertension and the prostate symptoms.
Race considerations, you mentioned those earlier.
Yes, while individual responses vary, population studies suggest African Americans tend to respond better, on average, to diuretics and CCBs compared to beta blockers or ECIs ARBs as initial monotherapy. Chinese patients might be more sensitive to beta blockers and need lower doses. These are generalizations, but can guide initial choices.
Okay, so tailoring is key. What about combination strategies?
The goal is to combine drugs with different mechanisms of action to maximize efficacy and minimize toxicity. A common effective 3-drug regimen, if needed, is often a diuretic plus ACE inhibitor ARB plus CCB. If a 4th drug is required, adding a sympathoplegic like a beta blocker or maybe clonidine or an aldosterone antagonist like spironolactone might be considered.
Are fixed-dose combination pills useful?
They can definitely improve compliance by reducing the pill burden. Many combos are available, like a beta blocker plus a thiazide, or an ACE-IRB plus a thiazide, or a CCB plus an ACE-IRB. The downside is you lose the ability to titrate the dose of each component individually. However, some studies show excellent results with fixed low-dose triple therapy, like temozartanol or diphenoclothalidone, even if not all combos are available everywhere.
How should BP be assessed in the clinic? And what's the target?
It's important to measure BP recumbent, sitting, and standing to check for postural changes. The goal is normalization for the patient's usual activities. The optimal target is still debated, but major trials like SPRINT suggest aiming for a systolic below 120 millimeter Hg significantly reduces events in high-risk patients, albeit with more side effects. Treating isolated systolic hypertension, say above 150 in older adults, is definitely beneficial.
And technology can help.
Yes. Things like home BP telemonitoring, especially combined with pharmacist case management, have shown real improvements in BP control rates. And always remember, if therapy isn't working, consider non-compliance, excessive salt intake, inadequate diuretic therapy, or those interfering drugs we talked about before blaming the chosen regimen.
Okay, let's circle back to our case study patient, the 35-year-old man. Applying all this, how would an elite professional approach his treatment?
Right. He's 35, BP 140/90, so stage 2 hypertension. He has significant risk factors: family history, obesity, dyslipidemia, prediabetes, and crucially, that ECG showing left ventricular hypertrophy, LVH, is objective evidence of end organ damage.
So high risk despite his age.
Definitely. While his family history points towards essential hypertension, standard screening for secondary causes, kidney function, electrolytes, thyroid is still warranted. An echocardiogram would be good too, to confirm the LVH is due to hypertension.
What about initial management?
Behavioral interventions, diet, exercise are absolutely essential first steps. But given his stage 2 hypertension and the LVH, medication is almost certainly required.
Which medication class to start?
Based on current guidelines, excellent first-line choices include a low-dose thiazide diuretic, effective, inexpensive, an ACE inhibitor or an ARB, good for potential long-term protection, or a calcium channel blocker. Beta blockers would be less likely first line unless he had another specific indication, like coronary disease.
Start single agent or a low-dose combo?
Either is reasonable, maybe start one agent, or a low-dose combo of 2, example, ACE-IRB plus thiazide, or ACE-IRB plus CCB. Then reassess in about a month. If more agents are needed, ensuring a thiazide diuretic as part of the regimen is usually beneficial. And constant reinforcement of compliance with both lifestyle and meds is critical for him.
That provides a clear, evidence-based plan. Now, we've covered chronic management extensively. What about the acute side? Hypertensive emergencies.
Right. Shifting gears to those rare but critical situations. A hypertensive emergency requires prompt control because of immediate, ongoing end organ damage. It's not just high numbers. It's high numbers plus acute damage.
Usually in patients with poorly controlled hypertension.
Often, yes. Or sometimes triggered by suddenly stopping antihypertensive medications like clonidine or beta blockers.
And the management is very different from chronic care.
Totally different mindset and approach. These emergencies can present as malignant hypertension, where there's active vascular damage, inflammation, necrosis of small arteries. This often triggers more renin release, creating a vicious cycle driving the pressure even higher.
And hypertensive encephalopathy.
That's a classic feature. Severe headache, confusion, blurry vision, nausea, vomiting may be focal neurological signs. If untreated, it can rapidly progress to seizures, coma, and death. Emergencies also include hypertension, causing acute heart failure, stroke, or aortic dissection.
So immediate intensive treatment is needed.
Absolutely. Requires ICU monitoring, often continuous intra-arterial BP monitoring. Careful fluid management. The key is using parenteral IV antihypertensive medications to lower the BP rapidly but controllably, usually within hours. Then transition to oral meds once stable.
What's the target BP drop? Do you aim for normal right away?
No. This is a critical point that distinguishes expert management. The goal is not immediate normalization. Chronic hypertension shifts the brain's autoregulation curve, meaning the brain is used to higher pressures to maintain blood flow.
So dropping it too fast is dangerous.
Can be very dangerous. Rapid normalization can cause cerebral hypoperfusion, insufficient blood flow to the brain, potentially causing ischemic injury or stroke. The standard initial goal is usually to lower the mean arterial pressure by no more than 25% in the first minutes to hours, or get the diastolic pressure down to around 110 millimeter Hg.
Gradual reduction is safer for the brain.
Much safer. Then over the next days to weeks, the BP can be gradually reduced further towards normal using oral medications.
Which IV drugs are typically used?
The ones we discussed earlier for parenteral use: sodium nitroprusside, IV nitroglycerin, especially if there's cardiac ischemia, labetalol, IV calcium channel blockers, icardocane clovidipine, phenaldopam, sometimes hydralazine. Esmolol is great for perioperative settings.
And diuretics are used too.
Yes, typically a loop diuretic like furosemide is given, especially with potent vasodilators like nitroprusside, to counteract the significant fluid retention that can occur as the pressure drops rapidly.
Okay, that covers the critical aspects of hypertensive emergencies. So wrapping this all up, what does this deep dive mean for you, our learner?
Well, we've really journeyed through the complexities, haven't we?
Mm-hmm.
From the basic physiology and causes of hypertension, through the body's intricate control systems, to a detailed look at every major class of antihypertensive drug, their mechanisms, their uses, their side effects.
The goal was to give you that comprehensive understanding, that elite professional level insight into why hypertension is managed the way it is, the science behind each medication class. Not just memorizing facts, but truly grasping the landscape.
And if we connect this to the bigger picture, I think this deep dive really underscores that mastering a field like this, even for a common condition like hypertension, it's all about appreciating that interconnectedness. The physiology, the pharmacology, the patient-specific factors. It's about understanding the delicate balance these drugs aim to restore.
Exactly. So here's a final provocative thought for you to mull over, building on everything we've discussed. Given the complex, multifactorial nature of essential hypertension and the body's incredibly robust compensatory mechanisms that we saw time and again, do you think we'll ever find a true silver bullet, a single drug that works well for the vast majority of patients? Or is polypharmacy, using multiple drugs strategically, likely to remain the most rational approach for most?
That's a great question.
And thinking further ahead, what role might emerging technologies, things like truly personalized medicine based on genetics or biomarkers, or perhaps even more advanced non-pharmacological interventions play in reshaping how we manage hypertension in the future?
Lots to think about there.
We certainly hope this deep dive has empowered you with both knowledge and insight into the world of antihypertensive agents. Until next time, keep digging deeper.